Welcome, students. This is the opening post for week 6. Ethical models for psychiatric nursing practice. I must say we're motoring along. Week 6 is halfway through. I've been really enjoying it. I've been really enjoying the critical thinking that's necessary to engage with you. I've been enjoying your critical thinking. I have been enjoying getting to know you through the Zoom sessions. It's really a pleasure. It's really a pleasure working with you. So we still got another half to go. This week, we're talking about tools that we can actually use in practice. So I'm hoping that this feels more relatable. Mental health practice is replete with ethical issues and moral dilemmas. I felt that quite strongly since I first started practicing. We're called upon to practice and advocate for ethical treatment of our patients. We're advocates. And we're advocates for social justice within mental health systems and within society. I believe that quite strongly. Unaddressed ethical dilemmas contribute to inequitable and, frankly, sometimes inhumane care for those with mental illness. And it contributes to moral distress for psychiatric nurses. And that gets translated as burnout. Burnt out nurses are not good nurses. And it contributes to significant health problems for nurses. Last week, we looked at ethical theories from more of an abstract perspective. This week, I'm going to address 4 articles which are addressing models for dealing with ethical dilemmas in practice. This discussion, it's still not prescriptive. Do this in this situation. Like, that's simply not possible. Like knowledge and theory, nursing ethics only becomes meaningful within the context of nursing practice. The Hagen article demonstrates how theory can be used to think critically about practice and help us to name our common experiences. If we can name issues, we're better able to make improvements and defend our practice. Park develops a rational, objective, and standardized process for dealing with ethical dilemmas through conducting a search and synthesis of the literature on ethical decision-making models. Oh, here's my little assistant for critical thinking. There are problems with using a standardized template for ethical models, and I'll get into that. Amba and Witterschoen demonstrate how a simple, comprehensive model for ethical decision-making called CARE can be combined with a narrative approach in medicine to make ethical decisions more responsive to the subjective realities of patients. We talked a little bit about ethical ethics before. This is a discussion within medicine, and it's not a discussion within nursing in the same way, which is odd because narrative is pretty closely tied to psychiatric nursing, particularly with the recovery-oriented model. Lastly, Pachanowski makes a case for education in ethical competency for psychiatric nurses. Catherine is faculty with Brandon University in our department. Right now, she's on leave in Scotland. She's pursuing a PhD with a specialty in ethics. Her master's degree is in ethics. So we're really looking forward to her coming home. Like, she has so much to add to this conversation. First off, the article by Hagen, oh, I don't know how am I going to say this, Helmeland and Nizik, my apologies. That article by Hagen and colleagues demonstrates how theoretical concepts can be used for thinking about and critically analyzing practice. One of Arthur Frank's quotes are about Foucault is that his ideas are good to think with, like they're tools to assist us in thinking. Theory can be a useful framework to increase our understanding and to improve communication with others about critical issues in practice. And Michelle, I realize that language can get in the way of, theoretical language can get in the way of communication as well. But I think the Hagen article does a really great job not letting jargon get in the way of a clear understanding. I'll be very interested to know what your perspective is on that. Anyways, Hagen and colleagues use two ethical theories, ethics of care and ethics of justice, to understand the dilemma of two conflicting perspectives in mental health practice: connection care versus duty control. This apparent dichotomy, I say apparent because I'm a strong believer in holism, and we tend to make divides that aren't really there. Anyways, this dichotomy is talked a lot about in mental health literature. Issues of care versus control. You see it particularly in forensic nursing and in acute care psychiatry. It is a reality of our practice. So Hagen et al. Designed a research project to explore what would be called the explanatory power of theory. So they've got this theory around ethics of care and ethics of justice. Do those theories have any power to actually explain things about practice? That's the explanatory power of theory. And I think they do. I think they do demonstrate that. And the practice that they're looking at is the treatment and care of suicidal inpatients. The theoretical framework clarifies theoretical concepts and articulates practice issues I've witnessed and struggled with, and still struggle with. I included two tables in the text that you'll be getting, the text post, based on the article that simplifies the differences between ethics of care and ethics of justice. So I can't, it's pretty hard for me to speak to them, but you'll be able to see them. So like on one side, we see ethics of care as relational, emotional, need-centered, holistic, contextual in nature. It pays attention to issues of trust, connectedness, closeness. Patients are seen as interdependent, not dependent or independent, but interdependent. And ethics of care values social connectedness and relationship and holism. We saw from Green 2012 last week, Carol Gilligan developed ethics of care in response to what she called ethics of justice. So ethics of justice falls under the biomedical ethics based on principalism, Beauchamp and Childress 2012 as well. So, ethics of justice, fairness, equality, rational, objective decision making, technical aspects, instrumental aspects, universal principles, clinical judgment. Last week, I made the argument that ethics of care could be used in combination with principalism, that is, bioethical ethics. Hagen et al.'s article demonstrates how both of those perspectives are useful for understanding the complex issues around caring for patients who are at risk of dying of suicide. The little tables that I've put in also contrast connection and care on one side with duty and control on the other. I think Hagen et al. Do a really good job of talking about this in the article, so I'm not going to go into depth about it. I'll be interested to know if you actually found it helped to clarify issues. Did for me. Oh, the sign of a good article is when you go, oh yeah, that's exactly it. That's what I've been thinking. Then you know that's a good sign. Relationship alone is not enough. Well, it might not be enough to keep people safe, but it is necessary. That's a bold statement. Emphasis on instrumental, technical policies, procedures like standardized assessments and documentation, which reflects an ethics of justice, puts relational, caring aspects, ethics of care, at risk of being ignored and devalued. And this is dangerous. I think it's dangerous for people. For instance, let's take Q15-minute OBS or even close OBS, suicidal OBS. It can accentuate patients' feelings of disconnection and alienation. And I realize that I've talked, I've used patient in this particular post because it's used in the literature I'm referring to. So Q15-minute OBS, patients report it can increase their feelings of alienation and disconnection. Observation without engagement contributes to feelings of intrusion, lack of freedom, and distress. Whereas engagement, observation, if you're engaged with the person, you can observe them, but engagement helps people feel safe and cared for. It reduces their anxiety. It gives you more information upon which to understand what they need to be safe. Safety can and must be provided within a framework of caring. We have such an emphasis on safety and risk management that we are neglecting caring and relationship in practice. And I think that makes for more chaotic and agitated environments and less safe environments and less healthy environments for patients and staff. The caring part cannot be abandoned in order to meet instrumental, technical, rational priorities. Big words, rational, instrumental, like the things we do to get something done, to have set outcomes happen. Technical, rational, referring to more of an empirical, ostensibly objective perspective. The theoretical perspective of ethics of care can be a balance so that prioritizing duty and control doesn't take precedence over connection and care. It's not that we shouldn't, it's not that we don't have duty and that we don't need to exert some control, but we're out of balance. It's devaluing and preventing connection and care, and that's a problem. Hagen et al.'s article provides a rationale for relationship-centered psychiatric nursing practice. Yay! Now, the article by Amba and Widdershoven, Dutch. I had the great luxury one time to speak at a conference in Finland, a psychiatric nursing conference in Finland. And so I met with, people from around the world, but particularly Holland and the Nordic countries. And so I was introduced to how they're facing the same issues that we're facing, and that there is a great deal of good psychiatric nursing literature coming out of those countries, that part of the world. So Amba and Widdershoven present an ethical decision-making model called CARE. It's standardized, and it's a step-by-step kind of do X, then do Y, and then do K to get to a result. And they illustrate how this model, CARE, can be combined with a narrative approach to facilitate fair and practical ethical decisions by bringing in the subjectivity of the client and more contextual factors. So the advantage of a narrative approach can be that it brings in the subjectivity of the client, the patient, and more contextual factors. We are natural storytellers as human beings. In this article, patients' narratives, the patient's narrative in the article talks about the value of communication in preventing seclusion. So they didn't think they could get the staff talking with the patients. Like, that was a little bit too weird for them. But they took the patient's narrative to the staff, and they looked at the patient's narrative to see what could be gained by it. Now, it's called a clinic, but it sounds like an acute care unit. The clinic under discussion did not value what they called a conversation culture. There was no expectation that nurses spend time with patients. There was no expectation that spending informal time with patients would improve assessment and provide support to prevent escalation or the opportunity to intervene at the early stages of agitation. The patient's narrative challenges the assumptions of that culture, of that clinic. There can be, for sure, institutional and policy constraints preventing attention to and communication with patients. One, it can be a matter of culture and expectation, and the other is that the institutional setting itself makes it more difficult, or it values other things and just makes paying attention to patients seem trivial or non-essential. Oh, I remember, hearing that attitude when I worked in acute care from psychiatrists. Not everybody, of course, but it can be there. This is important because without attention to and communication with patients, other institutional and policy work is ineffective, right? If you don't have that connection, you lose everything else. The situations are made worse rather than better. We need human environments. A work environment with frequent use of coercion, is morally distressing for nurses. Can make patients feel unsafe. It's especially moral distressing to nurses if there's little value placed on attention to and communication with patients in order to deal with those moral dilemmas. Listening to patient narratives is critical to effective nursing practice, to people feeling like they're heard, feeling like they're safe because somebody sees them. Listening to patient narratives is critical to job satisfaction and I think to the emotional health of nurses. Connecting heals us as well. Acts of empathy and kindness enrich the person offering the empathy and kindness. Listening to patient narratives is critical to respectful, collaborative, and humane care of patients. Now, this care model broadens the ethical discussion beyond the nurse-patient relationship to include institutional and legal contexts which impact an ethical issue. Consistent parameters and consistent processes, such as the care model, provide a framework and a guide for discussion and decisions in practice. We have some guidance of what can we do. It's clear. Patient and staff narratives, though, can provide access to life worlds and integrate diverse perspectives on the issues at hand. Narrative can add information about relational, caring, emotional, and contextual elements. So in ABAM, I forgot the name, AMBA and Widdershoven, they show how you can combine those two together. A standardized model that provides a framework, and it's a professional model. And almost needs the input of the subjective other, and narrative can give us that. Park does quite a competent job of literature search, analyzing, and synthesizing professional literature. And through that, she develops a rational, objective, and standardized process for dealing with ethical dilemmas. One could say that because she's followed, I think it's a woman, I'm not sure, because she's followed professional standards or academic standards for research and building knowledge, that the knowledge she builds is more objective because it's met these academic scholarly standards. Attending to ethics of our actions is important. We got, really. Park says patient safety and well-being are dependent on ethical decisions of healthcare providers, not only upon the knowledge and clinical skills of healthcare providers. In Doan and Barco, we learned that knowledge and skills only become nursing knowledge and nursing skills when they are enacted in nursing practice. In the same way, ethics exist in practical application? Park makes the case for a systematic, standardized model, or the well, not she presents a model, but she makes the case for having some kind of model for ethical decision making. It gives you consistency across decisions. It provides what's considered intellectual rigor. It facilitates communication and documentation, well, between certain people. And documentation over time can lead to the identification of ethical norms. A certain group of people are having a conversation on a regular basis about ethics. And if you look for themes afterwards, you can see what is the norm of those people who are involved in that conversation. So you can see where my critique's going to go. My critique of Park's systematic model is that professional models empower those who have access to and the capacity for formal processes of ethical decision making. Who does the model leave out? What knowledge is left out? What factors are not considered? The systematic model Park suggests is dependent on this techno-rational principle-based ethics with a veneer of objectivity. The God trick. Hagen and colleagues, their use of ethics of care perspective and or the narrative approach of Amba and Witterschoven both add a relational and caring perspective that would balance Park's standard systematic model. And I think it needs to be balanced with that perspective. Lastly, I think it was 2 weeks ago, I included an article by Catherine Pachinowski. She makes a case for why psychiatric nurses require education in ethical competency. And we don't have a formal course, but some degree of ethical competency is required for entry to practice. And psychiatric nurses are expected to be moral agents and critical thinkers. So it behooves us to help psychiatric nurses understand how to be competent in making ethical decisions. Mental health practice is particularly fraught with ethical and moral issues. Social justice is central to mental health. There's a relationship between social marginalization and mental illness. Mental health care is underfunded. People with mental illness receive less health services of all types than those who have some other kind of health problem. Psychiatric nurses, we have to balance issues of care and control in our practice. Psychiatric nurses must always be alert to boundaries and other ethical aspects of relational practice. When we say we care, it's fair that we're clear to people what are the boundaries around that caring. Psychiatric nurses regularly balance considerations of capacity and consent against issues of autonomy and respect. One of Pachinowski's statements stands out. She says, legal acts are not always ethical acts. Well, this can pose a problem for psych nurses. Moral distress is I think it's a significant problem. Therefore, having tools for identifying Thinking critically about and resolving ethical dilemmas is a health issue for psychiatric nurses. In conclusion, the readings this week provide tools for thinking about ethical issues in practice. And there's no shortage of ethical issues in psychiatric nursing. Dealing competently with ethical issues, or even dealing with them at all, is necessary to safe, humane care for patients and a healthy work life for psychiatric nurses. There are advantages to consistent, clear guidelines for practice and making ethical decisions. Socially valued principles help hold us accountable to recognizable standards. However, technical, rational, ostensibly objective policies, procedures, and models can be tools of oppression. Privileging some while silencing others. Ethics of care privileges relational, emotional, need-centered, holistic, contextual care. Narrative gives voice to other perspectives and contextual factors that might otherwise be invisible in healthcare. Psychiatric nurses would be, I think, well served by ethics of care and narrative approaches to practice. Well, see what you think. I look forward to, I'll be reading your discussion posts on the week 5 on ethics, and a summary post, the second summary post. I'm going to be in Calgary until Tuesday, late Tuesday, so I'll probably have the marks back late, like Wednesday for sure, or even Thursday for that week. I'm going to be behind. Okay, so enjoy, take care. There will be a discussion forum, Zoom, on the Wednesday and the Friday. Okay.